Goeiedag, good day, fellow South Africans and citizens of the world.
I've been looking around for salvation. I've been looking around for the truth. All around me I see frustration, and I looked all over till I found you. I sit and listen to your stories, and you're telling me, please don't worry. Lot in this world you should know, and love in life is where you should go. If you're looking for somewhere to go, if you're looking for someone to know, if you're looking for someone to guide you, then love in life will guide you. I know that life outside is so
Goeienaand, good evening, fellow South Africans and citizens of the world, and welcome to tonight's live stream. And tonight I'm talking to Herman Liebenberg, and we're going to be talking about a subject that's really not talked about much, but is very, very common, and that's obesity. And so we'll be looking at how obesity can be rectified and how you can get your life back on track. And without any further ado, let's get Herman on. Here we go. Here we go. Hi, Herman.
Good evening, Scott. Good to be with you again.
Great to have you on our show again. And
Thank you very much.
Tonight, Herman, we're talking about a subject that is not discussed as much as it should be, and it's about obesity. And it's very, very common in the world today. In fact, I was seeing that a huge percentage of the population are now morbidly obese.
Yes, indeed, yeah. Ranking-wise, we know that the Americans are the most obese population at the moment.
Yeah.
Initially, it was followed by the UK and then South Africa, but we've climbed the ranks, and we are now the second most obese country in the world, and England's the third most obese country in the world.
Wow. Now, a lot of that is because of fast food, isn't it? Like McDonald's and Kentucky Fried Chicken and stuff like that.
Yes, we have a couple of fat cats in our country. and they sit in a place that I'm not allowed to disclose publicly.
Now, how does someone know if they're suffering from obesity? What are these signs?
Okay, well, there are various things that we look at. The first thing is we look at a person's BMI. Now, a normal BMI is usually about 18.5 and let's say 25. And if you wonder what your BMI is, you can go into the internet and Google the BMI calculator. You just need your height and your weight, and it will work it out for you. Anything above 30 borders on something that we consider a major issue, and above 40, a BMI of above 40 is clearly indicated for a specific kind of surgery. Now, we sit with the problem that a lot of pharmaceutical companies have products, and obviously they want to sell their products because it's a billionaire's industry in the world.
Yeah.
Keeping that in mind, it works for a while. Usually it works for a while, but it's not long-term sustainable to be on it. And then if they're caught that they've added ephedrine or something to the medication, then they close the company and they just restart it and rebrand it and go on from there on. So the BMI is the first one. The other thing that we look at is, evolves around the different medical comorbid conditions, especially a patient with a BMI of higher than 35. In our case, I used to work with Professor Hein van der Walt from the Unitas Hospital in Centurion for about 15 years, until I was medically boarded due to liver cancer. We would look at 30 plus, a BMI of 30 plus, with a specific amount of and a specific type of medical comorbid conditions to qualify on the surgical side of doing weight loss surgery. Or what we refer to as bariatric surgery. He's an accredited international laparoscopic, metabolic, and bariatric surgeon, a very gifted man and world-renowned for the work that he does in bariatric surgery and esophagus cancers.
Right. Okay. So, what causes obesity? Why do people get fat?
Well, before I'm going to answer that question, I think it will only be valued if I refer to the stigmas around obesity. People who don't suffer from obesity tend to think that obese people eat all day long. If only they did, they wouldn't suffer from obesity. They're dumb, they're transparent, they're lazy, they're dirty. There's such a lot of stigmas that's attached to obesity, and it's actually shameful, because if you understand the rationale behind or where obesity comes from, it will change your perception of obesity dramatically. And that is what the role that the psychologist plays in the whole process of bariatric surgery. Well, the factors that causes it usually, well, it can relate to genetic factors. However said, genetic factors are usually more pronounced than what they really are in terms of the causal factors to obesity. And epigenetic factors, that is, in layman's terms, the way to describe it is you are born with a specific genetic predisposition, and environmental impact or influences either cause the genetic material to express itself or to be suppressed. And in the case of obesity, we find that in most cases, if there's an epigenetic cause, that the environmental impact basically forces the genetic predisposition to develop into obesity. Childhood trauma, and in specific physical, emotional, and sexual trauma, we consider that to be roots of obesity. And to explain that, what the brain does is if you go through childhood trauma and let's say you're a female, it's more pronounced amongst females specifically who were sexually abused. Then subconsciously the brain says, if I can make myself as unattractive as possible, the perpetrator won't try to sexually molest me or abuse me. We do find that among men as well, however, more pronounced among females. However, said not all the obese females had to endure that. In the case of males, specifically physical abuse, and in specific if they were abused in the form of bullying by, let's say, the father, the subconscious mind tells the brain, if I'm big and strong, I will be able to defend myself against the impact of the physical trauma imposed on me. And we usually refer to that as complex trauma, which is very complicated, but it's a direct causal factor to obesity. Malnutrition and the socio-economical environment a person grow up in do have an impact on obesity, as well as the availability or the shortage of food sources. We also find that different cultures have a different preference for, let's say, specific kinds of food, whether it's high in starches or whatever the case might be. And culturally, people have, or the children are born into a family where the perception of a plate of food is different to somebody in another culture, for example. So as an adult, they perceive that the plate must be that full and I need to eat everything, because we know the old story. Your mom says there are hungry people in Africa that doesn't have food and she's not going to waste it. So we programmed to eat all our food in spite of the fact that we've already fulfilled the need. So cultural orientations does have an impact on the causal factors of obesity. We do find that among female patients that hormonal factors can have an impact. However, said it's highly inflated when they explain to you why they suffer from obesity. On a lighter note, I always have a laugh. Well, after 15 years working with this, I've definitely heard all the excuses in the book. And if they come to me and say to me, well, I picked up weight because I was on an antibiotic, then I say to them, well, if you have that antibiotic, I will buy all the antibiotics of that specific source that's available, because I'm going to start a cattle farm and I'm only going to feed them antibiotics, and I will have the most prosperous cattle farm in the world. So unfortunately, sometimes they overinflate that. Psychological issues, very much so, specifically when we come to patterns of grazing, night eating syndrome, binging. There are a lot of eating disorders that people maintain, and that can cause obesity, obviously. Environmental influences like people who are trapped in a war situation, famine, natural disasters, who don't have access to food. The shortage of it implies that as an adult, when they do have access to food, they will try and absorb as much as they possibly can, to not ever end up in the situation they were when there were a shortage of food. I even find it among some patients who are diagnosed with obsessive compulsive disorder. They will not buy one specific item, food item. They will buy 2 or 3, even though they might not need it. And they will buy it for in case they feel like having more. So they kind of overcompensate in that sense. And I'm in a very brief way going to explain metaphorically how obesity develops in the body. Just keep in mind that it is far, far, far more complex than what I'm going to explain, but I'm going to do my best to just give you a synopsis of what happens.
Yeah, before you do, before you do, when I was a teenager, my first serious girlfriend, she was suffering from a thing called anorexia nervosa, which is the other side of the coin to obesity. Now that's quite common amongst young women too, isn't it?
Yes. Yes, and quite interestingly, it's a good thing you mentioned it, because the causal factors to anorexia on the psychological level is exactly the same as obesity.
Amazing. Wow.
The difference is with anorexia, you cause the organs in the body to be damaged and they can't repair. Whereas with obesity, you put pressure on the organs, and when you lose weight, you have the normal functioning of the organs. So anorexia really is the bad side of the coin.
Right. Oh, look, that makes sense. Sorry, back to what you were saying.
Sure. Okay. Imagine that this circle represents a cell.
Yeah.
Now, we have food intake that comes into the cell from here in the form of food. It metabolizes and it leaves the cell in the form of energy. That's amongst others why we eat, to have energy and to do what we need to do. Now, if you don't have a regular intake of food coming in, the top part of the cell, imagine that those are considered cell doors. They can open and they can close. Now, when you have regular intake, the doors are open, the food comes in, it metabolizes, and it leaves the body in the form of energy. But if there's an irregular intake of food, the cell doors close because they have to protect what is in the cells. And that is what we refer to as the adipose cells or the fat cells. So in contradiction to what people believe, you don't lose weight on the long run by not eating. You lose weight by eating regularly. And I'm not referring to graze eating, because that is something completely different. Regular intakes of food and water is critically important to maintain the balance in the body in terms of weight as well. So that is just a very, very simplistic explanation of what happens in the body.
Right. Okay. So what are the risks associated with obesity? You've told us that anorexia nervosa, you can damage your organs, but what about obesity? What are the risks there?
Well, the first one, very well known, is diabetes type 2, which we know with the bariatric surgery that I'll discuss later on is actually curative for people suffering from diabetes type 2, which is absolutely amazing, and it's worldwide accepted, and researchers indicated that it does have a major effect, and it actually cures diabetes type 2. Hypertension. We find that people also risk factors that they have evolve around the LDL cholesterol, the bad cholesterol in the body that clogs the arteries and can cause heart attacks and those kind of things, and causes heart disease, gallbladder diseases, osteoarthritis, and a very common one that we see is the obstructive sleep apnea, where people stop breathing during the night, and they usually then wake up very tired. And what do they do to get energy? They eat. So a lot of our patients are on the CPAP machines that provides oxygen during the night. It is something very difficult to get used to, but it does have a major impact in effect on obese patients, because when the body goes into a sleep mode, the chin kind of collapses and it obstructs the airways, and the brain doesn't register that you have to lift up so that you can breathe. And that causes sleep deprivation and tiredness that's associated with it. There's also certain cancers that's risk factors in terms of obesity, like endometrial, breast, colon, kidney, and gallbladder, as well as liver cancer. A low quality of life, and what I mean by that is people who eat the fast food stuff, the stuff that you mentioned initially.
Yeah.
They are really people who eat takeaways, especially the Americans, with all due respect. Some of them don't have kitchens.
Yes.
They basically live off takeaways because it's cheaper and it's readily available. And some patients do, the risk factors have bodily pains that can't be explained, almost like somatic pains in the body due to obesity.
Right. Now, one of the people watching asked, is intermittent fasting no good to combat obesity?
You will find various opinions on it. The intermittent fasting, as well as the keto diets and all those kind of things. The main question is, if you suffer from morbid obesity, is it something that is sustainable? It's almost like the flavor of the decade. And I do value Professor Tim Noakes' opinions on dietary issues. He initially stated that we need to get in carbs. Like before I ran the comrades, I was still in the stage where we had to do what we refer to as carbo loading. And then he changed it completely the other way around. And so you have all these trends that come and go. There will always be a search for a cure for obesity. I think that's the most lucrative pharmaceutical industry in the world. Next to that, I presume it will be Viagra or something like that. But yeah, so I hope that answers the question. So there's not one shoe that fits all.
Wow. Well, yeah, Viagra is a whole different story, isn't it? So let's.
Yeah, well, that helps with obesity. That helps you to lose weight. Let's refer to it like that.
Okay. What is the role of a psychologist when dealing with obesity? Because obviously this is a psychological issue, isn't it?
Yes. Well, we focus on aspects related to the assessment of the patient as well as the support of the patient. Now, if we look on the behavioral side of it, we look at previous attempts patients had on weight loss programs, and usually there's a list as long as an encyclopedia of diets they've tried, medications they've tried. We look at the eating styles, and that's why something like night eating syndrome is something that really adds badly to obesity, and we try and assess what kind of eating behavior the patient suffers from or follow, what their physical activity is. However said, it is a myth to believe that only physical activity will cause you to maintain a healthy body weight for the rest of your life. That is completely not true. But basic and moderate physical exercise, even if it's just walking, is complementary to losing weight. We also look at psychological issues like body image issues. There's a syndrome called body dysmorphic disorder, where people are not happy with their appearances, and they will do whatever it takes. Surgically, usually the plastic and reconstructive surgeons have issues with them, and that's why we assess them prior to surgery as well. But in the case of bariatric surgery, we also assess them for that. Then there's the cognitive and the emotional aspects that the role of the psychologist emphasize, and that's the person's cognitive functioning. If the person doesn't comprehend or doesn't have the cognitive ability to understand how the program works and why we do certain things, and if they can't grasp some basic ideas and issues as to why they become obese, it is a problem. So knowledge of surgery is something that we do focus on. We look at their coping styles and skills, and how they modulate their emotions. Very important. You find that some people, when they are stressed or anxious, tend to eat more, and others tend to stop eating. And we also look at the patient's emotional boundaries in terms of food and various other forms of psychopathology or abnormal psychological behavior. We also focus on the developmental history, and I've already alluded to the epigenetic factors, and that's a main thing that we look at. However said, there is one condition called the Prader-Willi syndrome. That's a genetic syndrome where the patients, they also present with different other kinds of medical and psychological symptoms. But a pronounced symptom of this specific Prader-Willi syndrome is that the brain does not react to the feeling of fulfillment, and they can't stop it. They can't stop eating. Younger children, I know, we've had a couple of them, where the parents would have to lock the kitchen, lock cupboards, lock the fridge, because they just can't stop eating. The brain doesn't have that filter, or the stomach doesn't send the message back to the brain that I'm fulfilled or I'm filled with whatever I've eaten. And then obviously, as I've already mentioned, we do look at the BMI of a patient, and in particular the surgeon will make a decision if a patient have a BMI of 30 and higher, and it all depends on the medical comorbid conditions that's associated with it. And obviously it will be monitored by a dietitian, and that's part of the multidisciplinary team.
Right. Okay. Now, there is a solution for people, and it's called bariatric surgery or weight loss surgery. Do you want to tell us what that is and how it works?
Yeah, sure. The word baros comes from the Greek word, or means, in the Greek it means weight. So it's referred to as bariatric surgery, coming from the Greek word baros, which means weight. We also refer to it as weight loss surgery. Now there's very strict criteria as to whether a patient qualifies for bariatric or weight loss surgeries. There's also different kinds of bariatric surgeries. The most common one and variations on it is the Roux procedure. We also have the sleeve and some other variations that the laparoscopic surgeon will decide on. There used to be a procedure called the JIB. It stands for jejunal ileal bypass surgery, that is now considered illegal in South Africa. It's a very quick way to lose weight, but the long-term side effects and the mortality rate on the long run is just enormous. And there used to be a well-known surgeon who used to do those procedures in South Africa, and he was scraped from the roll. And we've seen over the period that I was involved with this, we've seen so many patients who had the JIB, and where Professor Hein van der Walt will do a reversal on it and then do either a Roux or a variation on it, because the side effects is absolutely unbearable once you've had a JIB. And if there are people listening to this interview that have the JIB, I will strongly advise you, please consult a bariatric surgeon of repute, because you are going to die because of the complications on the long run. So that's in a nutshell the role of the psychologist, to assess and to support going through the whole process.
Right. Now, what does the laparoscopic surgeon do when performing the Roux procedure as part of bariatric surgery?
Okay, as I've mentioned, the surgeon will decide the variation on, if we look at the Roux, the most common procedure, bariatric procedure, he will do variations or do the typical Roux procedure. And he will keep in mind the patient's other medical comorbid conditions. So that brings us to the point of whether the surgeon will do open or laparoscopic surgery. Professor Hein van der Walt is a world-renowned laparoscopic surgeon. He's just absolutely gifted to work with the laparoscope. Now, with the laparoscope, after this, you will show an animated video on how it's done. But there are small incisions made in the abdomen, and the arms of the laparoscopes inserted through that to do the surgery. He's usually assisted by another medical doctor during the process. And unfortunately, we find that a lot of the obese patients also have a hiatus hernia. Basically, that's a tear that causes the gastric intestines to push through the tear, that causes what is commonly known as gastric reflux. And if it continues, it can actually, because it's basically acid that's pushed up into the esophagus, if nothing is done about it, it can eventually end up in either a hiatus hernia repair that's needed to be done, or it can present in the form of what is known as Barrett's esophagus, which is basically the beginning stage of esophagus cancer. And the surgeon will decide whether it's to the extent where it's already gone over to esophagus cancer, and whether he should do a esophagectomy procedure on the patient, or if he will do a hiatus hernia repair as part of the bariatric surgery. And in most cases, the obese patients, he does a hiatus hernia repair as part of the bariatric surgery. And the link that you're going to show now will, in an animated form, basically explain how the procedure works. It is fairly simple to follow it, but it's complex if you don't know the anatomy of the gastric system. So if you don't mind, Scott, I will appreciate if you will put that video on.
Sure. Okay, let me put it on now. I'll let you know when it's finished running, Herman.
Great.
Okay.
Thank you.
Okay, guys, here comes a video which will tell you more about bariatric surgery.
Bariatric surgery, or weight loss surgery, refers to a variety of surgical procedures for treatments of morbid obesity. Obesity is determined by body mass index, or BMI, which is calculated as the ratio of body weight over square of body height. The higher the BMI, the higher the extent of obesity. A normal BMI is between 20 and 25. An individual is considered morbidly obese if he or she has a body mass index of 40 or more, or of 35 or more if he or she also has obesity-related health problems such as diabetes, sleep apnea, or hypertension. Weight loss is achieved by reducing the size of the stomach. A smaller stomach makes the patient feel full faster and therefore makes it easier to reduce the amount of food intake. Roux gastric bypass. This is the most commonly performed bariatric surgical procedure and is considered the gold standard for weight loss treatments. The procedure involves 2 steps. Step 1. The stomach is divided into 2 parts. One small pouch at the top of the stomach where it is connected to the esophagus, and the rest of the stomach which will be bypassed. The 2 parts are separated and stapled. Step 2. Rerouting of the intestine. The intestine is cut at about 45 centimeters or 18 inches down from the edge of the stomach. The first part of the intestine, the duodenum, will be bypassed. The top end of the second part, the jejunum, is pulled up and connected to the gastric pouch created in step 1. The lower end of the duodenum is reconnected to the jejunum at a lower point. The new configuration has a shape of Y, hence the name of the procedure. How is weight loss achieved? Firstly, the volume of the stomach is now greatly reduced to a small pouch, usually less than 10% of the original volume, which is filled up fast after a small amount of food intake. This sends a signal to the brain that the stomach is full and generates a feeling of fullness or satiety. This helps to reduce the amount of food intake. Secondly, as the first part of the intestine, the duodenum, is bypassed, the amount of nutrition absorbed by the body is greatly reduced. In normal digestion, this is where most of the nutrition is absorbed. Malabsorption contributes to weight loss effect. Complications. While this procedure is proven as an efficient long-term weight loss treatment, it associates with significant complication risks. These include leakage along the staple lines and surgical connections leading to infection and abscess formation, stricture and obstruction of the digestive tract due to scar formation, dumping syndrome, nutritional deficiencies, and other general surgical risks due to the complexity of the procedure.
All right. There we go.
Right.
Yeah, back to you. And I just want to ask you one question about that video clip, and it just came to me while I was watching. I understand that 70% of a person's natural immunity is in the stomach. So how is that impacted if the stomach is reduced in size to just 10%? What happens to the natural immunity aspect of the body?
Okay, it is basically due to the amount of serotonin that you find in the gut that causes a higher immune system. The reality of it is, you would have noticed that the procedure the surgeon creates a pouch.
Yes.
In other words, the pouch can initially only hold 50 milliliters. It does stretch a bit depending on whether it's a male or a female, a child or whatever. It does stretch a wee bit. But you must keep in mind that the other part of the stomach is still there, and it still secretes all the enzymes that's necessary.
Right.
So it's not as if you take away the rest of the stomach. It's basically still there. So it does not have an effect. As a matter of fact, it have an exact opposite effect. It have an effect that it boosts the immune system.
Wow.
Because weight loss surgery is known for people having a better immune system as to obese people.
Yeah. Okay. Now, how do we determine psychologically if you qualify to have bariatric surgery?
Okay, the things that we look at first starts off with what's the motivation for you to go for surgery? In other words, what's the reasons why you want to have surgery? I look at psychopathology. There are certain psychological issues that exclude patients from bariatric surgery. Amongst others, people who are a risk suicidal. There are some mood disorders, some uncontrolled bipolar mood disorders, or even borderline personality disorders. There are various disorders that can disqualify a person. And if I say disqualify, it means if the person is not on a treatment regimen, then it can disqualify them. However said, if they have these conditions and it's well stabilized and they take their medication, they attend their therapy sessions with whoever psychiatrist or psychologist they see, we don't discriminate against them. As a matter of fact, we just keep the lid on and we make sure that they remain compliant on the treatment regimen that they are. We obviously determine whether the psychological causes of obesity is something that the patient understands. For example, if I'm going to use a lady again, let's say a mature lady had endured a childhood sexual trauma, and because of that she developed obesity to make herself less good looking in order to prevent the perpetrator or traitors from abusing her. If that person doesn't know that and have insight into it, it's all about control, because you can decide what you put into your mouth or what you are not going to put into your mouth. And on a psychological level, we go into a lot of depth, making sure that the patients understand that and that they are fully aware of the fact that those can be triggering factors to, let's say, binge eating or grazing or whatever the case might be. We do look at self-discipline. This procedure is deadly if a person doesn't have enough self-discipline. And we look at the patient's pre-surgery compliance to the program. We usually start 3 months prior to surgery and have a very strict follow-up and dietary protocol 3 months after surgery. So most patients have to lose at least 10% of their initial body weight prior to surgery, and in some cases, if they suffer from morbid obesity, especially the super obese, it can go up as high as 15%. Now, what some people do is they starve themselves to cause that, and it's very easy to pick up on it because we use various psychometric instruments to assess the patients in terms of whether they are risks or not. But if they don't lose the amount of weight prior to surgery, they will not be operated on, full stop. Specifically, in our program with Professor Hein van der Walt. And that is a clear indicator if the patient is compliant, because they have to send in their weight once a week. So we can monitor the weight loss, and the dietitian, as part of the multidisciplinary team, monitors the weight loss. And there are certain things, curves and statistical things that we know is indicative of whether they stuck to the program or whether they diverted from it. And people ask, but why do you lose weight if you go for surgery that's actually going to cause you to lose weight? The reason for that is your prognosis and long-term outcome and the amount of possible side effects after surgery are much less if you've lost the amount of weight determined by the dietitian and the surgeon prior to surgery. We also look at other psychological risk factors, as I've already mentioned, cognitive development, and specifically in younger patients. We have had some young patients where the mother or father or both are very involved in that child's life, and they make sure that the child stick to the program and not transgress. We sometimes have to make a judgment call. The surgeon makes the final judgment call by taking the report from the psychologist, the feedback from the dietitian, the questionnaires, the medical history, the medical comorbids. So the surgeon makes the final decision on whether that patient will be operated on or not.
Right, okay. So, what comorbid factors qualifies a patient to have bariatric surgery?
Yeah, well, definitely the BMI is most probably the most pronounced one.
Right.
And the acceptance and the approval on a psychological level and the assessment report that goes to the surgeon, which is a highly confidential report. It's not circulated to other members of the multidisciplinary team. Only the surgeon sees the psychological report for various reasons, and patients actually sign a document to that extent to make sure that no other person sees the psychological assessment report. And obviously the dietitian's feedback is very, very important. And the dietitian will look at the patterns and the weight loss as was given through to her over an extended period of time to make sure that the patient was compliant and stuck to the regime. She puts them on various phases, and each and every phase have different food types and sources they need to have as intake. They also use nutritional supplements. And you do get two kinds of procedures. You get the restrictive and the malabsorptive procedures. The Roux is something of both. It is restrictive in the sense that you have a pouch that can only hold so much. And the malabsorptive side of it is that you bypass a part where food is absorbed in the gastric tract. So it's a combination. But there are other surgeries that's either purely restrictive or purely nutritional in nature in terms of the absorptive in other words.
Right. Just on that same subject, what medical, dietary and psychological phases do patients go through when going through the process of this surgery?
We usually start with the pre-surgery process, and we refer to that as the psychoeducational part of it. The patient first attend a briefing by the surgeon to explain what it's all about, and from a psychological point of view, we also explain to them what the implications are and what we need them to do, and how they should follow the exact guidelines in the process. The pre-surgery assessment takes place, the preparation. In other words, a patient is informed as to what will happen even prior to surgery. Like the morning of the surgery, the physiotherapist will nebulize the lungs to make sure that there's no respiratory problems during the anesthetics or during the doping of it. And there's also information that we give the patient in terms of what happens during the surgery as well as after surgery, the post-operative care, which is incredibly important. And that's where a patient with suicidal tendencies that's uncontrolled become a very high risk. If after surgery you decide to eat a hamburger, I can almost guarantee you the pouch will burst, you will develop sepsis, and you will die within a couple of hours if you're not close to the hospital. So we have a golden rule that patients need to be close to the hospital for the first 7 days after surgery to prevent any of those kind of things. The post-operative care also include informing patients of a condition called dumping syndrome, which can occur after surgery. Basically, just boils down to if they eat food sources too high in glucose or sugar, and it presents with very low blood pressure, and the symptoms are just incredibly awful. Whatever they ate that caused the dumping syndrome, I can assure you they will avoid that for years to come. It is a terrible feeling. You feel as if you're really going to die because of the drop in your sugar, and there's a whole spectrum of symptoms. Some patients only develop dumping syndrome a month to 3 months after surgery, not right after surgery. But we inform them very clearly as to what it is, what they should do to prevent it, and what they should do if they do develop dumping syndrome. There can be leakages. The staples seal off, and it cauterizes the part of the new pouch and the rest of the stomach that's just loose in the gastric tract. But it can happen that there are leakages. Bleeding can occur, especially if it's patients who are prone to bleeding or who are on blood thinning medication who didn't declare it, because the surgeon makes the call prior to surgery how long before surgery they have to go off their anticoagulants or not. And the risk of infections will always be there. However, said with laparoscopic surgery, the risk of infections usually are very low. But if you relate that to open surgery, especially if there's scar tissue in the abdomen, and the surgeon have to do open surgery, which is a very rare thing in our clinic, or the clinic that I used to work with. And it is important for the patient to follow up after surgery. We monitor them for a very long period after that, not only psychologically, but dietary, and the surgeon will see the patient at various intervals for very long periods, even years after surgery, to make sure that they are compliant. And psychologically, we usually follow up until about 3 months after surgery, but in some cases, we do it over an extended period of time, depending on pre-morbid conditions and those kind of things.
Right. Now, Shirley has asked, what age is the norm for these operations?
It's usually between the ages of what we find is about 25 to up to about 60, sometimes 65. We've even had older patients, but the surgeon will make the decision in that case. If the patient is too old and too high a risk with other medical comorbids, he will decline the patient for surgery. And that they do in the beginning. So it stretches over a very long lifespan in order to do the surgery. But it is mainly determined by the surgeon himself.
Right. Now, once you've had the Roux and Y procedure, can you reverse it? Can you have your stomach put back together again, or is it all over Red Rover?
Well, I've never encountered a case where it's been done. There must be very, very good reasons if they do that. I haven't witnessed any of those yet. I presume that the surgeon will do a variation, but I don't think it's possible to have it exactly the same as it was before. We've never had a case that I am aware of.
Right. Okay. Now, just something that's been going through my head is the suggestion to me that if I go on a diet for, let's say, a week, and that's to lose weight, and then after the week of being on a diet, I then return to my normal eating habit, what the body does is, because you've been not providing enough food, is it actually it retains a lot more of the food that you're actually putting through your stomach than it would normally before you had the diet. So you actually put on weight when you even eat normally after a diet. Am I wrong in that suggestion?
No, you're absolutely right. It comes back to that metaphor about the cell. If the food doesn't come in regularly, the cell door closes, which means that it creates more and more fat cells. So if you starve the body of food and nutritions, then the cell doors close. So you will actually cause yourself to pick up more weight than you've lost. And that's a common phenomenon, that patients lose weight on diets, but once they stop, they every time pick up more than what they have lost ever before. So it's a progressive deterioration of the body in terms of trying to maintain a healthy body weight.
So what's your advice to people listening on the best way to keep yourself within the standard BMI rating?
Well, those people, there are some people who can't afford to go for bariatric surgery. And in their case, I focus on the psychological causal factors. We make them very much aware of it. We monitor them very carefully. And what I usually do is I keep them in therapy, or invite them in therapy. You can't keep them in therapy against their will, but I will invite them in therapy, and I will make sure that we follow the dietary instructions in accordance with the dietitian if they can't go for surgery or can't afford it. And we've had some long-term success. There are, every now and then, there are products that does have a good effect, and specifically with genetic manipulation, which I'm really not much in favor of, but apart from that, there are people who do have benefits on it. And the reason why I say I'm not a major supporter of it is because I'm not knowledgeable about what the trends are lately. But if it proves to be on the long term to be effective, and the efficacy is proven, then obviously I will support it. But I think time will tell that, and obviously you can only determine that once you have long-term research studies proving the stability of the patient's weight.
I'd like your thoughts on a thing called messenger RNA, which is obviously associated with a jab that happened a couple of years ago now. They seem to be now injecting just about anything that's alive, whether it's a plant or an animal, with messenger RNA to change the DNA. What are your views on that?
Unfortunately, I'm very skeptical about it. I recently watched a program on how they do it with food, and how the food that you take in causes changes in your genetic blueprint. Now, I'm not a geneticist, but to my mind, that is something that hasn't been proven to be stable until research can really prove it on the long run. I will be skeptic, but optimistic if I'm proven wrong, and proven wrong by real and solid good research only. Not pharmaceutical companies that cook the research to sell their products.
Yeah, no, you hit the nail on the head there. But it's interesting that King Charles has just authorized in the UK for messenger RNA to be basically added to anything like a soup. But he personally has a private garden that his vegetables, his fruit, everything is grown in, and that's the only thing he eats. And of course, it's all, perfect.
Organic.
It's organic. It doesn't have any mRNA additives or whatever. And even when he travels, they actually pick from his garden the food that they're going to give him when he's actually overseas. This is incredible hypocrisy, isn't it?
Indeed, it is. Well, not to attack him personally, but I think you need to have a certain amount of brains to understand the concept of DNA and all, and genetic makeup and those kind of things. And it's easy to approve it because they can produce mass amounts of food because of it. But he himself wouldn't eat that.
Yeah.
He eats organic food, and I'm fully aware of it. So it isn't hypocritical kind of stance that he holds. So I tend to think that you have to have a certain level of intelligence to understand certain things in life.
Well, I'm not going to dwell on Charles, but I just want to make one observation, and that is that he is absolutely ridiculous when it comes to attention to detail. Apparently, when he gets into the bath, it has to be exactly the right temperature, and the plug in the bath has to be put in a certain position. And if it's not in that position, he has a hissy fit. I mean, this guy is absolutely. Anyway, look, let's move on from Charles.
That includes his shoelaces that need to be ironed.
Need to be ironed. Yeah,
based on his toothbrush.
Oh God. Anyway,
well, at least we do need somebody who can create some humor in the UK. So he's really one of the clowns there, to my mind, with all due respect.
Well, we had a guest on last week who suggested that Charles is actually the Antichrist. And he gave some really interesting insights into why he said that. But let's get back to bariatric. What is the long-term outcome after bariatric procedures?
Okay, the fortunate thing is we do have long-term research studies going back more than 40 years. Earlier days, the way they performed the Roux and Y procedure was a wee bit different, but in principle, it boiled down to what we do nowadays. Nowadays, we do have variations on the length of the small intestines and those kind of things. But people who stick to the instructions on the long run do have a very healthy outcome. However, because it's a malabsorptive procedure, it is important for patients to stick to the nutritional supplements that's advised for them to use on the long run. And if people stick to being a normal human being with a normal weight, and not trying to push the limits of the pouch, there's no reason why they can't have a long-term success and outcome on the procedure. And we see that with patients. Well, some of our patients, well, the interesting thing is, some of the most beautiful females that I've ever encountered, I encountered via this program, the bariatric program, because they hide the beauty behind the obesity. And on the long run, there's one specific patient of ours who's actually become a photographic model.
Wow.
After she suffered from major obesity. And there are many other success stories. It just came to my mind now. But if you stick to and it's not a difficult thing. You just have to eat regularly, take your supplements, and don't overdo it. The same with alcohol. Alcohol is something very dangerous for bariatric patients because the amount of calories that's captured in alcohol, if you have to transform that into food, it will be an amount of food that you can't consume. So by consuming a lot of alcohol, you actually add the calories, which means that you sabotaging your own process. And unfortunately, that is a side effect that we have seen amongst predominantly men, and painkillers and sleeping tablets among females. Alcohol in moderation. I always say if one beer makes you feel tipsy, after bariatric surgery, one beer will make you feel like you drank a whole crate of beer. So you will have to learn to drink all over again. Some find it quite amazing to do that, and others find it annoying.
So bariatric surgery could actually help an alcoholic then, because they wouldn't be able to drink so much.
It's supposed to, but unfortunately, some of them don't care because the pouch can hold that amount of alcohol. The effect is just so much worse. It's like throwing alcohol directly into the bloodstream.
Wow.
So, and that is something that I actually forgot to mention. We do check for substance abuse and substance abuse patterns prior to surgery as a psychological thing, which can exclude a patient, definitely so. Alcoholism is one of the things that can exclude a patient.
Right. Okay, well look, Herman, thank you so much for joining us tonight and telling us about obesity and the options that people have. And look, I just want to thank you once again, because you've been in our show a couple of times now. And
I feel like a regular.
You are, yeah, absolutely, you are. And it's lovely to have you back. Is there anything you'd like to say to people in closing?
No, bariatric surgery is not for all, but if it is for you, just make sure that you get to a reputable bariatric surgeon. That is critical. There's a lot of cowboys out there, and we've seen so many of the let's call it mistakes that came through our process where it had to be reversed. So be very sure that you go to the right person and go and check that person's credentials. It's possible to do it nowadays. You're going to close off with a beautiful video that I always use after I've given my first presentation to the bariatric patients. It is a wonderful video to illustrate the metaphor of you have to go through a very painful process to have the benefits of a lifetime and to have a longer life expectancy. And we do know that bariatric patients do have statistically a longer life expectancy than people who didn't suffer from obesity if they stick to the regimen that they were informed about and that they should follow.
Right. Okay. Herman, thank you so much. And I look forward to our next chat.
Great stuff.
Okay, take care, mate. Scott. Bye for now.
Keep well. Thanks a lot. Bye-bye.
Okay, guys, that was Herman Liebenberg, and it's a topic that I think a lot of people will find very interesting, because I think most of us know someone, maybe a close friend, who suffers from obesity and could well benefit from listening to this program that we had tonight. I'm going to close off with the video that Herman referred to, and it's called An Inspiring Eagle Story. But before I do, I just want to say thanks to the mods for looking after the side chat, and have a great evening. And of course, this live stream video will be put up on Loving Life TV. Just for the record, our live streams on Loving Life TV have recorded over 10,000 views, in many of them last week. That's over 10,000 people have viewed the live streams on Loving Life TV. Obviously, after I put it up on that platform, and you can go and check that out in the archives for yourself. So, Loving Life TV is doing incredibly well. It is our main platform where people go and watch things. So, anyway, I just thought I'd let that little bit of information out. Let's have a look at this video about the eagle. Here we go. All right, guys, that was it. Have a great evening, and take care.